Okay, so this is the first case. This was a middle-aged person who came in with right upper quadrant pain, and the clinical concern was for acute cholecystitis. I'll scroll through these images and you guys tell me what you see. Show you the coronals.
There's kind of a T2 intermediate signal in the right, in the hepatic dome. It's a pretty large area.
Okay.
Yeah. Patient has a renal transplant, polycystic kidney disease.
They do.
Or sorry, maybe it's acquired renal cystic
No,
disease rather than polycystic.
Polycystic kidney disease.
It's polycystic, okay.
And then what do you think of the biliary tree?
The CBD is a little bit dilated centrally. Intrahepatic, there is DIL, and then it kind of tapers. I don't see like a lesion necessarily in the distal CBD, but it tapers.
Okay. And this is kind of tough to see, and I'll show you post-contrast as well, and we'll come back to some more images. So agreed, there is biliary.
Oh, wow, look at that. There's like all this enhancement.
So the posts helped us some. And then here was a CT done just a few days ago.
So, and the antrum looks bad. So is this like PTLD, or that definitely would be considered for me?
That's a great thought in somebody with a
it looks, is it coming from the like a prepyloric channel? I don't know, there's some kind of like polypoid component to it with mass effect.
So exactly, I think the morphology is important too. It is definitely polypoid, very large, involving the entire pylorus antrum. It's causing nice mass effect at the ampulla, and that's where that CBD tapered off. So we gave similar differentials. In the end, they did an EGD just recently, and this was a giant gastric polyp. It was 11 centimeter polyp with some superficial ulceration and areas of bleeding. And that's what had caused mass effect on the ampulla here. On the MR, I think it's a little sometimes easy to not see intraluminal masses, but when you see in the stomach, very nice frond-like morphology is appreciated when there's a little fluid in the stomach, hence. But smaller polypoid masses, I think, are easy to miss on MR if we're not specifically looking for it. And the presentation of this was unusual because of the location she actually came in with, more like jaundice and biliary symptoms rather than gastric outlet obstruction, which is what we would expect. So it's just a nice case of a large gastric polyp, not to be missed on MR in case it was smaller. It comes at you nicely on the coronals as well. And then on the CT, it was much easier to see. So this got endoscopically taken out and the patient was fine. Okay, next one. This was just a show and tell case. This patient had had a cholecystectomy a week prior to the scan. And one of our residents actually made this call, I think. So it's a good kudos case for them. So we saw a little bit of ascites. There was nothing in the cholecystectomy bed as such. But we still said, just being a week out, it's not unusual to have a little post-operative ascites. We still said, do check the acidic fluid to see if it's bile or do an Eovist scan. And then they did both. And it's just a nice example to show how Eovist actually helps us. So this was actually a bile leak, which declared itself really nicely on the 20-minute Eovist images. So even though it was not a localized collection in the cholecystectomy bed, I guess the teaching point was that when you see localized ascites. Don't just blow it off as postoperative fluid. It could be sort of a more diffuse bile leak, which a study like Eovist will help pick up. So one of the more popular uses of Eovist now in trauma and post-op cases. So just a nice leak.
So with Eovist, it's better than HIDA because you can localize where the leak is coming from. So if they do an endoscopic intervention, they have a pinpoint place rather than HIDA, which just tells you it's leaking, but doesn't tell you where it's leaking from.
Right. And I think this was like that tail-like communication, like Nelly said, we saw go to the hilum, which may be from the cystic duct stump where this leak was coming. So this was another cool case. This was also a great on-call resident call. So this person came in with nausea, vomiting, abdominal pain. And obviously on the X-ray, we see all features concerning for an SBO. No perforation, no pneumatosis or anything bad. And then once we start scrolling on our CT images, they had GFR issues, so we couldn't give them contrast. So I'll scroll through these images and see if you guys find where the transition is and why the transition is.
In the right lower quadrant, right there, there's like a filling defect or some kind of polypoid, something.
Right.
Is it like a kind of, I just wanted to see where the appendix is and clear the appendix.
The appendix was clear.
Okay, fine. So
IC valve was here, the TI
okay,
was
there it is. Yep, I see it too. And then there's
okay, there's our filling defect. So how do we put it all together, Nelly? What else was odd about the right upper quadrant?
So there's pneumobilia. I don't see a gallbladder. Okay. There's free air.
I tell you what, we thought one of this was gallbladder.
Oh, I see it right there. It's communicating right there. If you go anteriorly, you can see it communicating with the right there. Is that it?
Yeah.
With the bowel.
Yeah.
So then the gallbladder kind of eroded through the gallbladder wall into the bowel.
Yep.
And then caused a gallstone obstruction.
Yeah. It's just a cute little case. I mean, not easy for residents to make this on call, but especially because there were other punctate calcifications in the small bowel wall, probably from stasis or I don't know, something that they ingested, to pick out that this is a rounded filling defect. And I think Josh is on this. I think Josh said there was a post-op photograph which matched exactly this stone. It's a nice SBO Gallstone ileus. I wish the stone were radio opaque like they show in the boards on the Scout, right? This was radio lucent. But again, going back to looking at bowel on coronals, I think it stands out really nicely on coronal images and the pneumobilia also. So those were my quick cases.
So it's perforated, yeah? Is that why we have free air? Or is it just the free air is just the fistula kind of?
I think it's just may have been a cholecystoduodenal fistula or a cholecysto to small bowel fistula, and then it just kept going.
Oh, gotcha. Okay.
There's not a whole lot of free intraperitoneal.
I have a case.
Okay.
Would you be able to pause the screen share? I just want to make sure I am. Can you see my screen? You can see my screen?
Yes.
Okay, great. This is a patient who had a history of rectopexy. So a patient has a history of rectocele and had that pexed to kind of the sacrum area. And she had recurrent symptoms after surgery. So we got a defecogram to evaluate her recurrent symptoms. So on the initial, when I did the physical exam, she had a rectocele that you can see visually. And so when we got a defecogram, and this is when she valsalvas, you can see this right there. There's that herniates out. So you can see that visually when you do an exam. So So she does have recurrent rectocele right there. This is what we see imaging that corresponds to sort of the visual rectocele that she had on exam. In addition, there's more than just that. So when she valsalvas, you can see, and maybe this is more pronounced when she defecates. So here you go. So we said that we saw the rectocele, right? So when the contrast gets administered through the rectum. And here, when we take the initial, like normally this area should fill with contrast, like the rectal contrast. But in her case, it went up really high, probably higher above her area of like where it got pexied. And then when she defecates, there's more than just what we saw visually. So here, it looks so. We don't have prior imaging, unfortunately, so I don't have cross-sectional imaging to share with you. But the upper rectum sigmoid area prolapses as well. See that in addition to the rectocele that we can see, it prolapses and pushes it down. So it's actually a pretty complex prolapse. And then there's also a component of enterocele as well. So there's probably small bowel, and that's coming down into the peritoneum as well. So she couldn't evacuate at all because the upper rectum sigmoid that had a prolapse had completely obstructed her outflow. So she had no evacuation of anything during the defecation phase. So
it's very drastic, Nelly, outlet obstruction because of like an eversion, right?
Yeah, exactly right. It's exactly an eversion because everything was already pexied, right? Like, and so
I wondered if sometimes the pexy actually acts as a tether and
yes,
drag it down.
yes, that's exactly right. That's exactly right. So yeah. So then that point was already pexied up, so the lower rectum was fine, but then that sigmoid came down, or upper rectum came down, and this is what we see.
Tarun, do you want to go?
Yes, let me share my screen. Quick case from me. Let's see. Okay, can you all see the screen?
Yes.
Yeah.
Okay, so this patient had like some history of like biles, like cholecystectomy. Following that, there was bile leak. They had to place a stent, and then the question was whether there's a biloma and all. So we basically kind of did the scan. For some reason, I think this patient had renal issues, so also they could not give contrast. So this was the thing, and basically we see this kind of elliptical kind of hypointense kind of thing. There is also effusion. There's also kind of atelectasis in the lung. So any thoughts on this so far?
It looks geographic and it looks parenchymal. It could be subcapsular.
So this is that site of the cholecystectomy, and
Maybe a bile leak into the subcapsular region.
yeah, and I think that's probably how it kind of got read. Kind of looks like that. But then we did MR. Subsequently, it looks like this. It didn't really look like fluid there. And so what we did was basically kind of looked at the in and out of phase image, and this is the post phase images. So this was and the in phase images right here. So this was a case of like a pretty geographic area of fatty infiltration along the liver. And interestingly enough, yeah, it was so kind of deceptive. And actually not having contrast was something which kind of was not working in our favor. But fortunately enough, IR was ready to place a drain here. And they when they saw the ultrasound, they didn't really see anything. So fortunately enough, we had the MR by then, and we could tell them that this is like just fatty liver.
The T2 signal of the liver is really hypointense.
I think she's renal failure. Maybe
it's just a tire deposition.
Yes.
Yeah. Yeah, I remember looking at this case also. I think retrospectively the jaggedy
Let me
margins.
Yeah, I think we were able to, for some reason, the CT, but on MR, we were able to give the contrast. I think, let me show you the post contrast on this. So you can actually see the
Yeah.
vessels coursing through that. Yeah.
That was a fake out. I think all the fat was
What a
intravox.
great case.
Yeah.
Yeah, the thing I think which also kind of misled was the fact that there is like you could actually make out like a track or something from where they removed the gallbladder, and the question was biloma, and kind of just got misled into that. So
Do we have the pre-op imaging?
I don't think so. It was, I think, outside scan.
I think it was outside the
Yeah.
surgery was outside.
Okay, yeah, that was a quick one from me.
Nice.